first question this morning, and we're gonna pass the questions along. Okay. How do you know if you're a good candidate for deep brain stimulation? Mr. YouTube Specialist.
Well, actually, if you followed that pharmacology lecture, the classic way to know is if there's a big difference between how you are when your medicines wear off and how you are when your medicines are just right, then that makes you a better candidate, because the DBS actually works on that same circuitry. It's sort of unfair. You know, it would be fair if we said, oh, the people who don't get much response from the medicine are the ones who get the best response from surgery. But unfortunately, it's not true. The people who get the biggest response from their medications are the same people who get the biggest response from deep brain stimulation surgery. So that's one way to predict. If there's a big difference between how you are when you're on your meds and how you are when your meds wear off, that's one thing. In Parkinson's disease, there are a few other special cases. For example, people who have one particular symptom or problem that is debilitating for them but doesn't respond to their medications. You know, the classic one is tremor. You know, some percentage of people with Parkinson's disease will have a severe tremor that's really bothersome to them, and they take their Cinemet and their tremor doesn't go away. And we're better, even though one thing I may have said, but if I didn't, I should have said, one predictor of the effect of DBS that we use as a loose predictor is whatever the symptom or problem is that you're hoping will go away with deep brain stimulation. If your medicine makes it better, there's a reasonably good chance that the stimulation will also make it better. But the exceptions to that are dyskinesia. Medicine makes that worse, and DBS, if you do it right, makes that better. One of you actually was thrilled to tell me about how his dyskinesia had completely gone away since we operated. And tremor. Sometimes tremor that doesn't respond to the medicine will respond quite nicely to DBS. And the last thing I'll say, I talk too much. The last thing I'll say in response to this question, how do you know if you're a good candidate for DBS? We have a very systematic approach in the center. Some of you have been through it. We call it Fast Track, where actually all of the people on the panel, not this particular panel, but our panel, some of them are here, will do a risk-benefit analysis from their perspective. So I look at you a certain way because I have a certain type of training and I have a certain type of experience, and there are certain things I won't miss. There are other things that I am more likely to miss because neurosurgeons probably have a pretty bizarre way of looking at things. But Don Bowers, sitting on the end, helps me not to miss important cognitive issues. She's a cognitive specialist. And Sarah Fayad helps me not to miss important psychiatric or limbic issues, mood, which, you know, depression, for example, is very common in Parkinson's disease, and we want you to look as good going into surgery as you can, because the better you look going in, the better you tend to look coming out. So the way our process works is if Dr. Oaken or Dr. Malati or one of the movement disorders neurologists identifies you as a potential candidate for surgery, then they will refer you to that 2-day fast-track multidisciplinary risk versus benefit analysis program. You spend 2 days meeting all our people, then we send you home, and we all get together and talk about you behind your back. And we will then all ask the same question that you're asking. What are the risks? What are the potential benefits? What's the likelihood that this is going to make my life better? And is it worth the risk? So that's a very long-winded answer to a simple question. I apologize for that.
Thanks, Kelly. So our next question will be for Dr. Bowlby. On TED.com, this should have been your question, but on TED.com, I watched Dr. Ben Goldesser report the negative results of drug trials are rarely reported, and having been a guinea pig for several studies, is this true, that the results of these trials? Is it true that it's worth doing the results of these trials? Here's the question.
It is true that negative results of drug trials, in other words, an ineffective result, is not reported as often as it should be. Maybe even in the majority of cases, it's not reported at all. And I showed you that table of those drugs that were found to be ineffective for PSP. The top two of those, the two biggest trials, those were important trials. Those were trials, if either of those had succeeded, the FDA probably would have approved the drug for commercial sale based just on that trial. Probably, I'm not so sure that either of those trials is ever going to see the light of day in a journal. And that is not the way it should be, because then someone else can come along and they'll have to repeat the trial. And there's a lot of information that was derived from the contact with the patients in those trials, and now that information won't be available. So there needs to be at least some website where these things are posted so that future researchers can take advantage of all the hard work that's been put in.
Thanks, Dr. Golby. Next question is for Dr. McFarland. What effect, if any, does coenzyme Q10 have on improvement or slowing down progression of Parkinson's disease? How much coenzyme Q10 is good to maintain brain health for a normal person? And since we're right next to Sam's Club out here on this side of town, I'm sure everybody wants the answer to this.
So that's a really good question, and we've actually been working on this question, and a number of folks across the country have been studying coenzyme Q10. So what is it really? So essentially it's a vitamin, and it helps boost energy. Really what it does is help one of those energy producing parts of your body and your cells called the mitochondria. It's one of those powerhouses in your cells. And the idea is really there that we boost the energy, that we can keep those cells alive that are in the brain that are vulnerable to die, particularly those, we've been talking all day about those vulnerable dopamine cells in your brain that die off in Parkinson's disease as well as other Parkinsonisms. And the idea there is we give coenzyme Q10 and that those cells will survive longer. So I guess the second part of this really is, so what's the right dose? And how much should you take, and does it really work? There have been a lot of studies, a bunch of animal studies that seem to say that yes, it did work, and so that sort of prompted us to study this in humans. And there was recently a very large trial that looked at Parkinson's patients. And I'll tell you, so what you find on the counter, over the counter in your drugstores, typically is 100 to, I've seen as large as 300 milligrams. I'm not sure if anyone else has seen higher. I know you can get about 600 milligrams of CoQ10 online. It's a very expensive little drug. Not regulated necessarily either, because it's in the vitamin section of your local supermarket. So, but the study actually was looking at 1,200 milligrams. So, and actually we're looking at even higher doses of 2,400 milligrams. So that's a lot of little pills to take every day. Generally, it's really well tolerated, though. So I haven't heard of really any side effects. I'm not sure if any of you guys have actually heard of any. No one that's taken that high dose has actually complained about it, with the exception of the fact that the cost makes them sick. So, but basically, the Parkinson's disease trial unfortunately showed really no effect. And we are looking at other disorders, other Parkinsonisms, in fact, other disorders that are not Parkinsonism as well. So. I think we talked this morning a little bit about the PSP trial, and that there is some suggestion of a modest benefit there. So there may be some cause where we will talk to you about maybe trying to take it. Because it's such a well-tolerated drug, but it's over the counter, and the cost of medication is going down, it might be worth trying. But again, I recommend all of you, it's a vitamin-like drug. So in that sense, it's not necessarily designed to improve symptoms like levodopa, so that's going to help improve your symptoms. A vitamin you take on a daily basis, and the idea is that it's going to help boost your cells and keep them alive for a long period of time. Those we call disease-modifying, or we call neuroprotective type drugs. So if you're expecting to take the drug and hope that your symptoms are going to get markedly better, that's probably not the stance or the thing that you should go into doing it. But you should be taking it as if it were a vitamin to prevent sort of one day actually worsening. In that sense, you're actually kind of committing yourself to taking a drug for a very long period of time, perhaps years. So it is also another consideration to think about. So.
Thank you, Dr. McFarland. Dr. Fayad, could a diagnosis of generalized anxiety disorder, also known as GAD, all capitals, about 5 years prior to my official diagnosis of Parkinson, have actually been the Parkinson disease the whole time during that 5 years that I was suffering with this? And just a parenthetical note, this patient also has peripheral neuropathy for 15 years prior.
That's an excellent question. A lot of times patients will notice that they'll have mood changes, including problems with anxiety, worrying too much, and sometimes that can be one of the first signs. Obviously, you're not going to attribute that to Parkinson's disease until you start getting some of the other symptoms, the motor symptoms. But a lot of patients will complain of non-motor symptoms like generalized anxiety disorder. So it certainly is a possibility. It doesn't eliminate the need, though, for it to be treated. A lot of people with generalized anxiety disorder, whether it is a non-motor manifestation of Parkinson's or something completely independent, find great benefit in getting full treatment from that, whether or not it's a non-motor aspect of their Parkinson's or something that's completely independent. It was peripheral neuropathy. I'll pass that one.
So at the moment, we don't have any reason to believe that most peripheral neuropathies are related to Parkinson's disease, although you should, as Nick McFarland pointed out, with taking multivitamins and seeing your general doctor, watching out for diabetes, things like this are very important. And there is some evidence when you take dopamine replacement therapy, it can actually slightly change the vitamins, and you may need to be on some supplementation. And so it's important to be checking regular vitamin levels like B6 and B12 and things with your primary doctors.
I don't know if this is part of that question about neuropathy, if you're suffering from sensory symptoms like burning sensations or painful symptoms with your neuropathy, so I'm not sure that's the question. But it's really not an uncommon complaint in Parkinson's. We always think of Parkinson's to be this motor thing, you're having problems walking, your tremor, stiffness, rigidity, but there are a lot of other symptoms of Parkinson's disease, and pain sensations are very, very common. And extremely, obviously extremely problematic for a lot of folks. So it is something that we do want to hear about. It may not be a neuropathy, which is actually an injury to the nerve, maybe caused by many things. Most commonly, something like diabetes can cause a neuropathy. So we do need to exclude that kind of thing. But if it ends up being really Parkinson's related, then there are things that we can do to treat that, and we should do that. So thank you.
Got this great question that says, where is my lobster? All right, which one of you guys put that one in? It's the guy in the green hat. Okay, is it better to start medication when first diagnosed or to hold off as long as you feel okay? I knew somebody was going to put a trick question in here. It turns out that there's no right or wrong answer to the question as to when to start medication therapy, and everybody takes a different view as to when is best. But I think it's fair to say that this should be a decision that's made jointly between you and your physician, And the things that I look to from the patients, the information that I find useful in informing the decision is whether any of the symptoms at all are impacting your quality of life, or if you're still working your ability to work. And whether you're having any balance problems, or or might be at risk of falling or hurting yourself in some way by not taking the medication. There are some experts that believe that if you take the medication early, it's going to have some sort of magical, protective effect against cells dying in the brain. This hasn't really been shown clearly in any research study, or at least any that I have read. And so I think it really comes down to, are the symptoms disabling to you at all? And you shouldn't be really trying to delay levodopa therapy or dopamine agonist therapy for some, potential unrealized benefit down the road. You should really think about, if these symptoms are disabling, take the medications to try to make your life better today. There is a myth in the literature and a myth all over the internet that cinnamon is toxic, it's going to accelerate disease progression. And this is really something that's unfortunate that it has popped up. Many people have suggested that it popped up as a byproduct of pharmaceuticals trying to sell more of the new Parkinson drugs, so sort of giving the old drugs a black eye. But again, there's not much evidence to support this. There are 2 blog spots on National Parkinson Foundation under the What's Hot in Parkinson Disease blog on their main website. One blog is on, does levodopa accelerate disease progression? Summary answer, no, we don't believe so. And when should I take my medications for Parkinson's disease early? And so there's more details up on that website on National Parkinson if anybody is interested. Okay. Next question. You want to answer that one? She wants to get the
Okay, there was a question here about what to do when they won't let you give your loved one their medications, or they won't listen to you in the hospital about your loved one needing their medications. And there are a lot of nodding heads in this room at this moment, because this is just such a universal problem. And actually the National Parkinson Foundation got so much feedback about this problem that they did this huge campaign that some of you are familiar with, particularly if you attended last year, and you may have gotten an Aware and Care kit. If you don't have one, you should let us know, because we still have some in clinic, and you also can get them through the National Parkinson Foundation. And what they figured out is they've done multiple studies which have shown that about 3/4 of the time, that means 3 out of every 4 people admitted in the hospital, they screw something up. So if you go to the hospital, get better, and 3 out of 4 times, at least one dose wasn't given, or was given wrong, or you got a medicine you shouldn't get when you have Parkinson's. There are actually certain medications that when you have Parkinson's, they can aggravate your symptoms. And many people in this room are aware of how important the timing of medicine is. In the hospital, because there are hundreds of people being cared for, there are certain medication administration times. 4 times a day might mean 8 o'clock, 1 o'clock. It means certain times to the nurses. Those aren't the times that your body is accustomed to and depending on getting that dose of medication. So in these Aware and Care kits, there are some tear-off sheets that you can pass out to the healthcare team, your nurses, your doctors, whoever else comes around. So it doesn't look like you're just a demanding, complaining person or care partner. It says from the National Parkinson Foundation, I have Parkinson's, I need my medication on time, every time. This is a list of medicines that should be avoided in Parkinson's, and this is a list of safe alternatives. And you providing that shows I'm not saying this. Look, someone important is saying this. Some of you might say, look, I had one. I've gotten a lot of feedback that those have been very instrumental and helpful. But another thing you can do is you can ask permission to give your medicines from home. Don't ever do that without, we don't advise doing that without having that special notation, the chart that's been decided on, because then they might give you the thing you're supposed to get and you already gave it, and then you get double doses, and maybe they don't know how to check interactions because they don't know you took something. So it's much better to only do that if that's something the doctors are aware of and agreed upon. but it can be very aggravating. This is a recurrent problem.
Next question is for Dr. Golby. Yesterday, there was a press release that SERI 120 was the nurturing trial, the growth factor trial was released as a negative result, meaning that they applied growth factor to the brain. This was their second attempt at that, and it was negative. And does this mean we should give up hope on growth factors or other new therapies for Parkinson?
Well, it certainly doesn't mean we should give up on new therapies. There are lots of approaches to slowing the progression of Parkinson's besides growth factors. Now, growth factors are a large, complicated group of proteins that enhance the growth and repair of brain cells. And there's different growth factors that affect different parts of the brain. And just because that one growth factor failed doesn't even mean we should give up on growth factors. It may be that the growth factor was administered in a way that didn't work. None of them have worked so far, but they are promising, and we should not give up on them.
I agree. So I don't want people to be discouraged because that large trial in nurturing is the name of SERI 120 was negative, and there are several other promising therapies coming besides growth factors that you'll be seeing in the near future. Dr. Foote, several of these questions, and so let me paraphrase a few. How long do the effects of DBS last? And what are the criteria for a person with PD to qualify for DBS? And everybody says it will give me speech problems. So how long, criteria, speech problems? I'll give you 60 seconds.
He knows that I can never answer a question in 60 seconds. So how long does it last? Well, it's made out of metal and plastic. So it's going to be around long after you're gone. Now the battery will deplete, and for most people, in I'd say 3 to 5 years, the battery will run out. And we address that problem by opening the same incision that we put the battery in, pulling it out of the pocket of scar tissue that is around it, unplugging it from the cable and plugging a new one in off the shelf and putting it back in and sewing it up, which takes me about 20 minutes or so. So in terms of the hardware itself, it lasts forever, at least by human duration. Now, how long does it work is a more complicated question, and I'm sure that's really what you were asking. It works and continues to give benefit so far as long as I can tell. We have patients, you know, they're still alive 20 years after having deep brain stimulator implanted, and they're still getting benefit. Now, if you remember what I said earlier, deep brain stimulation does not cure Parkinson's disease. And you still have Parkinson's disease. So we all know that Parkinson's disease will predictably get worse as time progresses. So the answer, the way I answer this question is, if this is your functional status 10 years ago, we're all on a downhill slide, right? All the time. That's depressing, but that's the human state. When you get Parkinson's disease, your functional deterioration accelerates a little bit. The slope of decline gets a little steeper, and you lose your abilities faster than someone who doesn't have Parkinson's disease. If you get a good doctor who knows how to manage your medications, he might bump your functional well-being up, and then your Parkinson's disease will continue to progress. Deep brain stimulation works as a big bump in that disease progression, basically, in that not disease progression, but functional ability. So what we're trying to accomplish with deep brain stimulation is to make you the most highly functional human being that we can. And if you're going along getting worse and you get to the point where you have DBS and it bumps you up, now you're a lot better. Well, as long as it's turned on and working as it should continue to make you better than you would be without it, but you're going to continue to deteriorate. And you may reach a point 5 to 10 years later where your functional ability actually is lower than it was before you had your DBS. Does that mean it's not helping you anymore? Well, just ask somebody who's had a DBS for 10 years if you can turn it off. And they'll say, no, because if you turn this off, I can't move. And so, anyway, that's another, I think that was about 48 seconds. So the effect lasts a long time, but it doesn't cure Parkinson's disease. Does it affect speech? Sometimes. Sometimes it can adversely affect speech. And that's actually a really good question. We do a lot of research on deep brain stimulation, and not just to find out what kind of great stuff it does, but also to try to figure out if it's having any adverse effect on people. And so Don Bowers, who's not here, has tested hundreds of people before and after to see if their cognitive function is altered, if it's better or if it's worse. And one of the things that we and others have consistently found is with one of the targets that we use to treat Parkinson's disease, a fairly consistent small deterioration in verbal fluency. So if you have trouble finding words for things, that might actually get a little worse if you have DBS. And it stands to reason, at least in my mind, that brain surgery doesn't come for free. You know, if you're going to pass something through the brain, that's a delicate, fragile computer. You know, you don't go sticking things in your computer and expect it to work right. So we try as hard as we can to find the least invasive way to do what we do and have the least impact, adverse impact. But that is one of the adverse effects that we sometimes see. And in our analysis now, for example, we tailor the operation that we do to the needs of a given patient. So one example of that might be if you're already having substantial difficulty with word finding and verbal fluency, then we might choose not to use that target that's been associated with deterioration in that function. We would do it a different way.
Great, thank you. We're going to do 3 more questions and then we're going to have lobster. How does Parkinson affect vision, Dr. McFarland?
So I'm just looking out of the room. Just a number of folks are actually wearing glasses. So it's a complicated question in the sense that in aging our vision gets worse. So it's not just Parkinsonism that makes vision worse. But let me ask another question. How many of those of you are wearing prisms in your glasses? Can I see hands? Who's got prisms in their glasses? Prisms. Okay, so several of you. So there are a lot of reasons why perhaps you may have vision problems, and the short answer is yes, Parkinson's does cause some vision problems sometimes. But why that is not 100% clear. So there are a number of things. So number one, people with Parkinson's, we see this mass facial expression and decreased blink. So dry eyes can certainly cause blurred vision. There's also tear production can be reduced. That can cause blurred vision as well. Another thing that can factor in this is, the reason I mentioned prisms is that people get eye movement issues. And one of the things as we age, we have more difficulty at looking down and in, and particularly reading becomes more difficult. So we have to look down and in to focus on things close to us. So prisms sometimes are useful for that reason. And then in some of the Parkinson's disorders, so we talked this morning about something like PSP, patients have problems actually looking in different directions. They can also have problems with double vision. And now, not all of us think of double vision. Sometimes it can be very subtle, and it actually is really, it's double vision to us. For you, it may just be blurred vision, or interpreted that way. And that's something that an ophthalmologist, or preferably a neuro-ophthalmologist who specializes in neurological disorders, should actually look at. Okay, so there are many different causes of this, and I think we often do refer patients to specialists to actually look and figure out what's the cause. Then I also have a number of folks who actually say they've been to their ophthalmologist and they run through this entire list, and yet they still have some mild blurred vision. It's not a loss of vision, and I'm not sure exactly how to explain that fully, but definitely.
Well, one way maybe to explain it is that in the optic nerves, which connect the eyeballs to the brain, it's not actually a nerve, it's actually a tract of brain tissue, and there are dopamine synapses in that tract of brain tissue, and they start breaking down fairly early in the course of Parkinson's. It's not usually enough to cause you any problems, but in a marginal case, you could have a vision problem for some other reason. It could make a difference, and it's a subtle thing, but it's measurable.
So if you're playing Trivial Pursuit and they ask you, is there a cell in the eye that makes dopamine? The answer is yes. It's called an hemacrine cell. And it's also, people are using it now as a marker of early Parkinson disease, looking into the eyes. Something like that. Okay, moving on. Dr. Golby, is taking hormones okay with Parkinson's disease?
Taking hormones, you mean like estrogen, I assume, is what the person needs. Estrogen replacement to retain a youthful appearance. There's no... estrogen can have odd effects on Parkinson's. Sometimes it could make it a little better, sometimes it could make it worse. Young women with Parkinson's who get pregnant, and during pregnancy there's a high level of estrogens, they usually get quite a bit worse in their Parkinson's during their pregnancy, and then they improve after they give birth. Some young women who are having menstruation, they find that at certain points in the cycle, their Parkinson's symptoms are really different. I would generally suggest not messing up the whole picture by taking hormone replacement in my patients with Parkinson's. It's just one more thing to introduce some kind of uncertainty into the whole health picture that I, as the doctor, don't want to have to worry about.
I would probably say, would you say that if somebody actually has specific symptoms that they need it for, that might be a different situation. So if you're on it, it doesn't mean everyone in the room should stop it. But what I think probably what you say, what you're saying is you wouldn't take it if you don't need it. But if there's a good specific indication, would you recommend?
Right, of course, if you have an endocrine problem that requires hormone replacement, absolutely. But just to take it for cosmetic purposes, I think is not wise.
I should say there was an old study, actually several old studies, and one recent one where they looked at women who had their ovaries and uteri removed, and they looked at when they developed Parkinson's disease, and there was some notion that the hormones that are produced actually were protective, and has led to some research into whether or not estrogen is protective for Parkinson's disease and may prevent Parkinson's disease or cause it to occur earlier. It's a black box. Nobody knows the answers, but there's actually some interesting work. Hormones are too complicated for neurologists, so we leave that to endocrinologists. So in general, we just, as they say, punt those questions away. Okay, last question before we have our lobster goes to Dr. Fayed. The form we fill out at every time we have an appointment has some really dumb questions. Does anything interest you? Are you neither happy nor sad, or maybe just in between? And I usually leave it blank because I don't know what the answer means. And what about all these forms? And is it important that we really fill these out? Is it really helping anybody?
So you don't like our forms? Okay. Actually, those two questions are really important. This is funny. It can kind of indicate to us whether or not you're having a problem with depression, depressed moods. Another thing that people with Parkinson's will commonly present with, and they won't even really know what it is something that we call apathy. And it's just kind of like a lack of interest in things. You just don't want to get up and go. usually the patient's spouse will be the one who really brings it to our attention, because they'll say, you know what, like, they don't want to do anything anymore. I can't get them out of bed. They don't really seem sad, but they just don't want to do anything. And it actually has a big effect on the quality of life of not just the patient, but the spouse or the family. And the important thing about actually like answering that question is that if any of that is going on with you, we can try to help you with that. And we're pretty good at doing that. And it can improve your overall quality of life, improve the quality of life of your spouse or partner. And most people really do come to appreciate that.
Thank you, Sarah. So with that, how does lunch work? Do they all go all at once for it? And survive? Is it a survivor style lunch, or is it? So Amanda is upset at me because I didn't bring copies of our new book that's out this month called 10 Secrets to a Happier Life with Parkinson's Disease. It is available on Amazon and on Smashwords, and is translated in over 20 languages. And Dr. Martinez, who's our fellow, is in the back, is translated into Spanish if anybody speaks Spanish, or Portuguese, or Bengali, or Marathi, or any of these other dialects. But at any rate, my apologies for not bringing any of the books this morning. And thank you all for coming.
Thank you.